In Zimbabwe, multitudes feared for their lives when they first learned about coronavirus outbreak in China, Wuhan, and the spread of the virus in Italy and Brazil, claiming thousands of lives. On the 21st of March 2020, Zimbabwe recorded its first COVID-19 case, and 2 days later, the country recorded the first death of the socialite Zororo Makamba.
Our deepest condolences goes to the Makamba family for the loss of their son, Zororo Makamba.
Although the news of his death caused fear, panic, uncertainty, a surviving family of 4 diagnosed of COVID-19 share a narrative of hope.
Pandakabatwa COVID ndakafunga kuti ndakutofa pakazara pakazara muriwo pakazara maonions mapotatoes huku dzakazara muyadhi dzakadyiwa ndaenda kuisolation kutotanga kuti spread one papa kozi atofunga kuti vanhu vava kutofa hatichaoni vamwe vanhu tikatogova zvimwe zvinhu mahosipitari mamwe ndakasata ndikapa vamwe ndikadidi ndikapa nhumbi ndikapa vanhu. I'm a mother of 5 who were affected by COVID, but we have survived. Now I'm strong, I can even water my garden and sweep my yard, clean my house. I'm going back to work now. This is now I'm from work, I have to sleep.
To contact with somebody who was in contact and had tested positive. So because of that, the rapid response team, during those days, I don't know now, but during the time when we were positive, they would test you according to who you got in contact with. So after testing, that's when they came with the results and they were positive.
However, their journey to survival was characterized by discrimination and isolation.
Takazviringidzika zvakanyanya kuti vhiringike ibepa resocial media rakabudawo zvakaipa vakatinyora zvakaipa vakanyora zita rangu id address zvokuti vanhu vaitouya achitora imba iyoyi maphotos. Even up to now ndiri munhu anoita zvekubata nemaoko ndinotengesa hakuchina munhu anoda kana kutenga zvinhu zvangu because vanongotya kuti musha wecovid zvokuti ndatodzekera upenyu hwangu.
Getting the COVID virus, first of all, we were in the top 20. There are so many questions that you ask yourself. Why me? Out of a population of over 10 million in Zimbabwe, why us? Okay, what wrong have we done? Those things somehow make the healing process difficult. Then, not that we're just positive. The next thing, we're all over social media. We're in newspapers, the radios are talking about us. Okay, it wasn't just one person who was positive, but the whole family, including the daughters. You ask yourself, what wrong have these 3-year-olds done? What wrong has this 10-year-old done?
The outbreak of coronavirus around the world raised fear, and predictions were made that Africa was going to be the most affected at a global scale. In the case of Zimbabwe, predictions were that in the winter season, infection cases would skyrocket.
Those fears were based on what really has been happening globally. If you look at Asia, Europe and the Americas, the numbers, the outcomes that they've been seeing there, they've been really good numbers. So I think we have always appreciated that probably the pandemic was yet to really hit Africa or Zimbabwe, for instance. So we really anticipated that probably we would find ourselves in a similar scenario. The wording that is usually used is they talk of peaks. We probably anticipated that we had not yet reached our peak as well, and we anticipated that our peak will probably be coming around maybe during the winter season, which is June, July, August, and we thought probably, we would have a similar trajectory of the number of cases as well.
These predictions were as a result of pre-existing socio-economic factors, which include long queues at public transport areas, crowding at water bowser stations, and informal trading centers. Impracticality to isolate because more than one family occupies a single household.
Far from it ukuthi kube le social distance la, because lapha kulama families ayi-3, lapha is rented house i-2 rooms lezo mama ba rente khona, then ngale kulabanikazi bendlu lapha futhi 2 rooms kulabanye abahlala khona. So njengokuthi abantwana I think bafika 6, and abantwana ngabantu labanothi vele bafuna ukudlala. So kuyabuya labana bangale 2 laba balapha bedlala phandle. Even abantu abadala njengokuthi lapha kurentwe 2 rooms nxa avela kula social distancing yakhona ekhuluma, because kulala kuyomela ukuthi lilale nje kokuyispace, abantwana bayadlala, awukwazi ukuthi badlala lo usuke ngaphi, laba bakwazi badlala la lo usuke ngaphi, so vele kunzima.
And immigration. Migration was attributed as the main cause of the increase of COVID-19 cases in Zimbabwe.
So abantu lapana wawayisukuthi abaningi bahamba ukuthi bayathanda, but kwakuyisituation ababebuya bafuthi because abanye they were being raped, abanye killed, baningi abafight ngebhodi bephila izindlela esifanele kusenzakala izinto ezinjalo, uzophanga abantu uduthule egangeni. Understand? Egangeni lapha kwaba yi-survival of the fittest.
I don't have to border what one border in town. To coordinate on all authorities. As South African soldiers, and the bicycle of the facilitator movement around in good today. So it was kwanza kuona hivi COVID actually in the public. Our statistics because most of people who are coming back or going there, they are using the bush.
Although migration of Zimbabweans from South Africa and Botswana is suspected to have contributed to the spike of COVID-19 cases in Bulawayo, Dr. Mlilo says otherwise.
As the Ministry of Health, we are in the process actually of going through a COVID review process. We will be analyzing our data and reviewing the whole response as it was. And probably once we do analyze our data, then we can really talk about when our peak occurred and if that has really already happened. I probably have to admit that we are still yet to fully understand, to fully appreciate the massive differences on the progression of the pandemic. That is probably if you are comparing Europe and Africa, or maybe if you are comparing specific African countries, South Africa was really largely hit. If you compare South Africa with us, you note that there are very marked differences in how the pandemic progressed. Zimbabwe's, our numbers so far haven't been really that bad, if I may put it across that way. If you're comparing that with America, which has been really hardly hit, and South Africa as well, and where they've really experienced huge numbers of deaths. I think, we are still yet really to fully understand why those differences really came about. I think that's point number one. At this point, probably we can only offer probable reasons, theories, something that probably would fully understand, or we'll fully understand later when we do our review process. But I would like to maybe profile possible reasons. One of those maybe the limited gateways, Zim into Europe. In Zimbabwe we have, for example, 3 international airports, and it will be interesting to look at how active these hubs of entry were. Where did we really receive a lot of visitors from the COVID hotspots, if I may put it that way, during pre-COVID or just at the beginning of the pandemic there. It will be really interesting to look at the sheer numbers of travelers that came into the country from those hard-hit regions.
Another migration strategy to combat COVID-19 was from tackling infections to benefit Africa, TIBA Zimbabwe, through the pilot policy brief research project carried out from May to June in Bulawayo to strengthen COVID-19 response in Zimbabwe.
Was about strengthening the COVID-19 response in Zimbabwe, COVID-19 diagnosis among the frontline health workers. The reason why we focused on the frontline health workers is because from the early days of the epidemic, the frontline health workers were people who were at a higher risk because they were facing a lot of people that were coming to the hospitals with these conditions, either unknowingly and also knowingly. And at times it was also a challenge to know what the people had without a proper diagnosis. So this strengthening of COVID-19 response was to try and make sure that our frontline health workers, we really understand and strengthening them in the way they are going to be responding. And we had quite a number of objectives that we wanted to highlight. The first one was also to try and understand what is the burden of COVID-19 among this group of people in terms of exposure, current infection, and past infection. And secondly, we will also try and understand the diagnostic capabilities of the antibody tests that were actually going around and being used to actually see their sensitivity and specificity. And at the same time, if we were going to also find out that there were some people that were infected, we wanted also to assess the cytokine storm, what's really happening during the infection period, in other words. So basically, these were the key objectives that we were actually trying to bring across in this research.
Government was supposed in its response to respond according to our obtaining environment. Number one, we should have known that, for example, we don't have the necessary medical facilities and medical equipment as compared to other countries like South Africa. We should also have recognized that we don't have sufficient financial stamina to introduce any facilities that might want to be introduced. And therefore, in my view, measures that government should have taken should have been measures that is consistent with the surrounding environment of our own situation. For example, instead of closed markets, we should have emphasized on saying, how can we ensure that there is social distancing in the markets? Instead of shutting down transport, we should have said, how can we implement measures to avoid infection while people are in public? We should not have talked about we are renovating such a hospital. If you look at all the hospitals that were said to have been renovated, don't go in Blawa, for example, there is nothing that happened there. It was just an issue of speeches that were coming to say we are renovating. But up to today, there is nothing that has happened. Go to the Joshua Mkabugo hospital along the road to my place where I stay. Up to now, it's preparations and renovations. But in reality, there is nothing that has happened. Look at the UBH hospital, which had then been turned into a COVID-19 patient take-in center. It caused a lot of chaos. So in my view, our response was shambolic. Our response was bad. It's only that we are lucky that COVID-19 did not have as much effect and as much impact on our population like it did in other countries. If it had, with the level of ill preparedness that we had, I want to tell you the death levels would have been catastrophic.
It is now 6 months in lockdown, and according to the Ministry of Health and Child Care's COVID-19 report, as at 1 November 2020, Zimbabwe has recorded 8,374 cases, 7,927 recoveries, and 243 deaths. According to these statistics, there seems to be a high recovery rate, and the provincial medical director explains the reason why.
Since there has been no cure for COVID, what we offer at our hospital is called supportive care, which means if you have a fever, we give you paracetamol, an antibiotic. Paracetamol, your fever comes down. If you are in dyspnea, if you can't breathe properly, we hook you onto oxygen, help you breathe, and so forth.
We couldn't afford some of the things that people were saying we should use. So what we did was, every day in the morning, I'll take from the moment we wake up, would bath, would steam, bath, wash the clothes, clean the surfaces of every place. At times we won't have just that soapy water, clean the surfaces, and then have our breakfast.
Kushambidzika nokudya healthy zvakabikika zvakaibva nechikafu chakawanda zvinenge zviya kuti vanhu vanenge vanzwa kuti lese munhu abatwa necovid, rubetsero runenge kuchidiwa rwakawandisa pakudya, pakukanselewa, pakunamata.
What has been the role of the church has been, number one, as churches we have directly reached to our brethren with the material support. Where churches have been failing, for instance, as our church at some point we failed to directly meet the needs, we were linking with other churches, linking with other organizations, and linking with other philanthropies to say, we have so many people in this area, can you come in and assist? And then people were coming in to assist those people in terms of their material needs. But also there were spiritual needs, because remember when we locked down, we thought that after 21 days, we're going to open up. But we had to go for up to 3 months. And we are technically still in lockdown. So we then had to come in as a church with interventions for psychological needs, in terms of counseling, in terms of coming in with interventions that are not COVID risk, but counseling the brethren.
Yeah, COVID iripo ndinobvuma nditangira mumba mandiri kubvamo nevana vangu. COVID iripo. Nokuti ndakatosvika pakuda kutomboluza mwana wangu, iyeyo ndine mwana wani. Akaposa afa mwana wangu, ndichitofunga kuti aiye akati mama ichando ndinobva kugweruko ndakabawa nemabayo echando, iyo iri COVID. Even kubasa kundotongoiona kuti COVID iriko. Pamapatients atiri kuona takatarisa iriko COVID. Ndiri kukumbira kuti vanhu vamaintaine masocial distances. Zviro zvirikutaurwa nehurumende zvitevedzerei, muvhare zvese, mudzivirire kuti kana uchingova nayo COVID zvive kuti unofa, asi ukangoteverawo zvinenge zvataurwa unogona kurarama.
We actually make the song for the babies to understand that every time you have to wash your hands, wash them with soap, and it was like a process of washing hands, washing our clothes, cleaning the surfaces.
Before wash our hands, wash, wash. We play, then we wash our hands again. Before we eat, we wash our hands, wash. If we blow out, we wash our hands, wash. If we blow out, we wash our hands, wash. We blow, then we wash our hands away. Before we eat, we wash our hands, wash. Before we go to the toilet, wash our hands, wash. Before we go to the toilet, wash our hands, wash. We play, and we wash our hands away. Before we go to the toilet, wash our hands, wash.